All right. Well, thank you for two really outstanding talks on very complicated subjects. I'm joined here with Dr. Nee, and Dr. Kuo is also here. He's just getting connected right now. So we will get started with a couple of questions for Dr. Nee related to SIBO. So first of all, let's see. Is there a link, or what is the link between SIBO and the pathogenesis of fatty liver? Is there a link there?
Yeah, so that's actually a really interesting question. In looking at the literature, there are definitely studies using, again, various ways of defining a positive SIBO, or a positive or abnormal breath test in NAFLD. But the consequences of that are not clear, right? So they're usually retrospective kind of associations kind of studies showing that, oh, there's more fatty liver if you have SIBO, there's more inflammation, or whatever those kind of things are. But unfortunately, the it's just their correlations, and they're not well done. So that link is still unclear, even though there have definitely been studies that show there's more SIBO in that population.
Okay. So why not stop PPIs for SIBO testing if hypochlorhydria and PPI use are risk factors?
Yeah, these risk factors are taken from old studies, and then in the newer studies that have been done, PPI doesn't show a difference. And I showed that one study that didn't show a difference between on PPI or off PPI. There's still purists, though, who just believe that, yes, it influences it, so why even have that in there? So yes, you could take it away, but just to be clear about the studies, the evidence shows us that some studies showed a correlation and some studies did not show that correlation. So in general, even reviewing all of that literature, the North American consensus said you don't need to stop the PPI.
Okay. All right, great. So here's a question. Is it reasonable to change from a lactulose substrate to glucose in a patient who has repeatedly positive breath tests with lactulose? And when do you repeat their tests?
So switching from a lactulose breath test, so using the substrate glucose instead of lactulose if you've gotten a positive test. Yeah, I think it's really about your index of suspicion. If it's just literally that, you repeatedly get a positive test and you no longer want to treat it, I think that that's just a discussion about the limitations of bacterial overgrowth breath testing. I typically don't try to switch between the substrates. I think that patients have there are some who have very strong feelings about which substrate they want to take, because Dr. Nee, you're underestimating my SIBO by using the glucose, or I want treatment, and what they're asking for is I want to be treated for my IBS symptoms, right? So I just have that discussion with them really about what the limitations are, as opposed instead of switching between the substrates.
All right, I'll just ask this one last one, just follow up about use of glucose. Is someone's asking, is since most of glucose absorption is in the jejunum, if you do a glucose test, are you measuring small bowel or large bowel bacterial overgrowth?
When you're using glucose, the question is if you're using glucose, are you evaluating for small intestinal or
large? Just
colonic?
presumptions because of saying you're going to absorb a lot of the glucose in this.
Yeah, you absorb most of that in your small intestine. It should not hit the colon. So it's really assessing small bowel as opposed to colonic.
Okay. All right. Great. All right. So Dr. Kuo, welcome. So can you describe post-viral gastroparesis, and is there expected time for recovery from that?
So I think that viral syndromes are extremely common, and that some people after intestinal flu can have a protracted recovery. It's really 3 months or longer where these symptoms persist, possibly with severe pain or weight loss, where people start to entertain the possibility of gastroparesis. At that point, they may check a gastric emptying scan and find it delayed, and then that probably gives us a sense that it is post-viral gastroparesis. I think the benefit of it being post-viral gastroparesis is, frankly, but many of those patients do recover if they don't have any other comorbidities. Eventually, maybe after 3 to 6 to 9 months or 1 year. If they do have comorbidities, and these things include other concomitant DGBIs, such as irritable bowel syndrome, other chronic pain syndromes, other nervous system disorders and such, that may be the harbinger of engaging another unfortunate part of the body, the GI tract, maybe the upper GI tract, in a protracted and possibly more permanent lingering situation.
Okay, great. Drug question here. Would you use Motegrity as a prokinetic for gastroparesis?
Yes. So I would use Motegrity. Obviously, that it's not a panacea. Motegrity is a medication that has both lower GI properties and upper GI properties. You cannot get it approved in the U.S. for upper GI properties for insurance companies. So I will say that they have constipation, and you may have to go through several hoops to get it treated for constipation, use it for constipation. I think it is helpful in those who have pangut motility, documented symptoms of constipation, treatment for constipation with upper GI symptoms, and that is not uncommon. There is some emerging evidence that treating lower GI symptoms does improve upper GI symptoms. And since Motegrity can benefit both, I do think it is helpful, but not by no means a panacea.
Okay. So Dr. Nee, couple of questions about antibiotics. And so is it ever worth using antibiotics other than rifaximin for SIBO, considering the increased risk of C. diff?
Yeah, I think this is really about like that as a provider, what my comfort is and how much I really think this is bacterial overgrowth. And then for the patient, their assessment of risk, right? That I tell patients, yes, rifaximin was trialed, but all of those studies were really from IBS for the most part. Yes, they were used in SIBO, but the efficacy and the side effect profile, we feel so much better about because of the large number who did not have any side effects with rifaximin. With C. diff, then when I tell patients, this is a medication that also treats your sinusitis and then also your pneumonia and your toe infection, but can also give you C. diff, then that lessens a lot of my patients' desire to treat something that maybe is a false positive.
And then do you have a maximum number of times you would treat someone with rifaximin in a year?
Yeah, I think on my last slide I said, right, that we don't even know what those repeated dosages, like what exactly does cycling mean for the patient for, is this safe? And target 3, rifaximin was used for IBS diarrhea 3 times. So that's the reason why we always hear, well, it's safe up to 3 times. But there's really no data otherwise about using these antibiotics repeatedly in SIBO and whether or not 1, is it safe? 2, what is it exactly doing? 3, like what risks are there? Nobody's ever followed our patients to actually figure out, if there's actually a much higher risk of developing other complications later on.
Okay, great, thank you. Dr. Kuo, I know Dr. Kuo is still here, has some video issues, so we're doing audio only. So in cannabis hyperemesis syndrome, how do you define daily chronic cannabis use? And does it depend on how much you use? And is there any association with medical marijuana as well?
Absolutely. Great question. So in my experience, cannabinoid hyperemesis is overly diagnosed. I believe that there are benefits to cannabinoid modulation in issues with nausea and vomiting. And I do have patients on various supplements of cannabinoids, whether it's medicinal, pharmacological cannabinoids, or even marijuana through dispensaries and clinicians that I trust. So the strict definition of cannabinoid hyperemesis has to be heavy use. So that is not just once or twice per 2 weeks. That is like every day, at least multiple grams a day of heavy use for several years. And then the cessation of it for at least 2 months with resolution of their symptoms, complete resolution of symptoms. Most, in fact, it's very rare that a person actually meets this criteria because they stop it, their symptoms still persist, or frankly, their use of cannabinoids or marijuana is not really extremely high. It's medicinal, low grade, or occasional use. And so ultimately, for me to call them cannabinoid hyperemesis, they have to have many long years, at least 3 to 5 years of heavy use, moderate to severe every single day, and cessation with complete or near complete resolution of the symptoms after 2 months. Most people do not meet this criteria.
Okay, great. And then Dr. Kuo, there's a question here about GLP-1. So how long should people be off GLP-1 prior to gastric emptying studies and prior to endoscopy?
It's a good question. So I think that when you look at gastric emptying studies, up to 40 to 60% of patients on GLP-1s will have abnormalities. You have to really ask yourself, why are you ordering a gastric emptying study on somebody who is on a GLP-1? I would have to at least wait. Typical half-life dose is 1 week, so I might have to wait almost a month for them to be off GLP-1s to get a more accurate baseline measurement for gastroparesis. And if GLP-1s are taken for certain indications, that is not practical unless the patient is really debating about continuing GLP-1s or not. So rarely, frankly, am I ever faced with that situation. And then what was the other GLP-1 question?
Like how long do you wait before endoscopy?
For endoscopy, actually, I don't hold them. The Society for Anesthesiology has a very strict approach where they recommend holding it, but the ASGE, the AGA, and the GI societies do not recommend holding them, and it'd be extremely tailored. We, in our own retrospective review, have found we definitely do find residual gastric contents are increased, but if it impacts the endoscopy, rarely, if ever. Does it lead to complications? Hardly ever. What do you define as a complication? Potentially somebody that gets intubated for aspiration. And the answer, that's extremely, extremely rare. I think in 500 or 700 cases, we only had one that went to aspiration. I think in practice, I think continuing GLP-1s is reasonable if you're doing conscious sedation because you have protected airway. If you're considering MAC endoscopy, for upper endoscopy in particular, then probably that person should have general anesthesia to protect the airway. But if it's conscious sedation, then I do not hold GLP-1s in my practice.
Okay, great. Dr. Nee, there's a question about what do you tell your patients who are concerned about leaky gut, and how do you test them for that?
Yeah, I think, leaky gut is, I actually was just talking about this because somebody asked me about SIBO, but that it's one of those pop culture, it's interesting, right? And the idea of permeability in our GI tract isn't new, and we are investigating permeability. But I think that SIBO and leaky gut are two different things, right? That's important to know. And that the idea of leakiness, the kind of correlate that we're looking at is really permeability. So if people have questions about permeability and those kind of chronic GI symptoms, I think that often I'm willing to say your diagnosis is consistent with IBS diarrhea. There is this evidence about leaky gut, right? So far about glutamine, about these tight junctions, things like that. So, but it's really not enough for us to kind of interfere or to try to treat at this point. We do not know enough.
All right, and then Dr. Nee, there are just a couple questions here about other kind of treatment strategies in SIBO. So one of them is, do you use probiotic therapies, and how long would you treat for before you might see anything? And then also, would you ever use any prokinetics to help with the MMC?
Yeah, so I don't use probiotics to treat SIBO, and I do not use prokinetics to somehow prevent SIBO. So the reason why is there was even a small study that showed that the patients who had SIBO were more likely to be on probiotics, and then they stopped the probiotics, and then they repeated the breath test, and it actually became negative. That's one. And then secondly, for the prokinetics, it's an interesting idea if you think that the reason for the positive breath test really is that they have overgrowth. So you want to prevent that by moving the small intestine or giving a promotility agent. But again, you can see that article that shows that it's actually a transit issue. So if it's already fast, we are just looking at something where the GI tract is moving a little faster, and that's why it became positive. So I don't particularly use a promotility agent to prevent or treat the bacterial overgrowth. If they have constipation, if they have gastroparesis, if they have other symptoms, yes, I'm willing to use the promotility agent. But I think for SIBO in particular, I don't think there's enough evidence for it.
Okay. All right. Well, terrific. Well, thank you both very much. We're a little over, so I think we'll call it here. Dr. Kuo, Dr. Nee, that was fantastic, and thank you for your expertise. So for everyone, this concludes day 2 of the course. We'll resume again tomorrow at 8:30 Eastern time again, and tomorrow it focuses on liver and pancreas. So look forward to seeing you then.